Diabetes in pregnancy is the most common medical disorder we face during pregnancy. Today, we're going to discuss about diabetes in pregnancy. I'm Dr. Swapna, consultant at BirthVibe by Rainbow Hospital, Hydernagar branch. Today in this discussion, I'm going to be joined by Dr. Rakesh Boppana, eminent endocrinologist, specialized in treating diabetes in pregnancy. Welcome to BirthVibe by BirthVibe by Rainbow Hospital, where we give all of you the knowledge to make the complex cases discussed in a simple language so that you are at ease to understand these cases. Hello, doctor.
Hello.
Welcome to the discussion. Diabetes is the most common medical disorders in pregnancy. So how do you think the woman who is going to plan pregnancy should go through this? Because most of the times, pregnancy is the first thing where women go through investigations. Before that, they never undergo investigations. So what do a woman expect when they're planning pregnancy?
Before going into diabetes and pregnancy, so today the two things which everyone agrees, pregnancy age, common age, women become pregnant has moved. So earlier it used to be third decade, now it is becoming fourth decade. We are seeing women in their 30s and late 30s becoming pregnant for the first time. And then diabetes also moved one decade earlier.
Yes.
So earlier it used to be a fourth, fifth decade, like say people in 40s, 50s used to get. Now it is coming in like say early 30s. So both overlap at this point. So diabetes, earlier we used to think only of gestational diabetes. A lot of new terms have come up. So one which we would like to discuss today is diabetes in pregnancy, gestational diabetes. The two which are common in pregnant women. So one is gestational diabetes. Everyone heard of this. So this is diabetes coming in pregnancy, maybe after 24 weeks. This is the most common term. So now what is diabetes in pregnancy? So diabetes in pregnancy is women who are diabetic becoming pregnant. Or people who for the first time
Are diagnosed to be
to become diabetic while
getting their
investigations done.
So these two are two different things. There's a gestational diabetes and there's a diabetes in pregnancy. Now, a woman who already knows that she's a diabetic and then she's going to plan pregnancy. So what is it that you advise her?
Okay, now this is called overt diabetes or diabetes woman becoming pregnant. So in these cases, what we say, see for diabetes, there are a lot of medications which are available, like more than 10 kinds of medications. But in pregnancy, the safety of all these medications is not known. So there are only one drug which is known to be safe, that is metformin. So this is the only drug we can give in any woman who has become pregnant. So if you are already a known diabetic, now you're planning pregnancy, I want all of these women to meet your endocrinologist 3 to 6 months ahead, check your glucose values. First thing is get your sugars under control, then plan pregnancy. Even when planning, we have to make sure you're off all these medications, because by the time you know you're pregnant, you're already like say 8-10 weeks. So these drugs are already in the system for 8 to 10 weeks. So we want to remove all these drugs, make sure we put you on drugs which are safe in pregnancy, and then you conceive and then continue to your pregnancy.
So preconceptional counseling is very important. Maintain their HbA1c levels before they plan their pregnancy and change over to the safest medications which are safe in pregnancy.
Yes. Two things, change your medications
And then
get your sugars under control.
HbA1c. So what is ideal HbA1c?
So ideal is less than 6.5. It's not possible for most of the people, but ideal if you say is less than 6.5.
6.5. Okay. So are there any parameters you tell them to control before other than HbA1c?
In over diabetes or type 1 diabetic population who are becoming pregnant, we do advise. So get your RFTs done, get your eye checkup done, get your routine diabetic checkup done before you become pregnant.
So that, it becomes easier during pregnancy
manage.
Because in pregnancy, all these complications might flare up. So you want them to check it. Then how a woman who doesn't know that she is diabetic, she has never undergone any investigations, and then she comes to pregnancy where we do a routine investigations and we found her to become pregnant. Her HbA1c levels suddenly are 8 and all. So in these women, does the treatment, how do you counsel them?
So these are the population where they get their sugars checked for the first time and then they know they're diabetic. So here we look at the values. Say how high the sugars are, and then we try to see what is the risk, what is the age of the mother, and then how difficult it is for them to achieve pregnancy. That is also has to be considered. So the advice is patient specific. So it's not the same for some a 25-year-old who became pregnant and a 40-year-old woman who has become pregnant. So we have to go case specific in these cases. But ideally, if the values are like say not too high, like say about 10, 10 and a half, somewhere in between 7, 8, though they are high, we can manage.
What are the investigations you want us to do initially when they come for pregnancy to diagnose diabetes early so that, they don't...
So there are a lot of guidelines which are formed, WHO, ADA. They all say when a woman becomes pregnant, you have to check for sugars. At the time when they become pregnant, a woman who is non-diabetic, still you have to do a OGTT.
Okay.
So it's a 75 gram, it's done in fasting. It's a 75 gram oral glucose tolerance test. Fasting, we take one sample, we give 75 gram glucose, we do it 1 hour, we do it 2 hour, and HbA1c.
If that is normal, again you want to repeat after 24 days.
Yes. Because if this is positive, then they're already diabetic and then we go through the management. If this is negative, we have to redo the test again at 24 weeks.
24 weeks. Okay. And then if her HbA1c is around 6 to 6.5, but OGTT comes to be abnormal. So then they are followed up first. Initially, what is the advice you gave them?
So 6.5, I think mostly we're talking like the new term which has come, EGDM or early GDM, where they're not over diabetic or not fully
diabetic.
So in these cases, most of the times we go with diet. We explain the diet. They're not in known diabetics. They may not be eating the right way. So diet alone does help. We ask them to check sugars either through continuous glucose monitoring or through glucometer readings. And then once they come back, if they're all good, then that's the only thing they'll require. Serial monitoring along with diet.
Yeah. So first thing is you want them to put in a medical nutritional therapy diet, equalize with the dietitian, nutritionist, and then you sugar monitoring. How frequently you want them to monitor?
So initially we say, because you're diagnosed with diabetes, we did an OGTT. We don't know what your home readings are. OGTT is like a glucose. You give glucose, the values tend to come high. So the OGTT values and our regular home values are different. So when you eat regular food, your values won't come that high. So we want you to check your glucometer readings, self-monitoring blood glucose values at home, and then check for 3 days continuously. Come back with the readings. Based on those readings, we actually make a plan. We don't make a plan based on your OGTT.
Yeah.
So we make a plan based on how
your diet control.
Your diet control is, and based on the diet, how well you're able to manage the values and how values have come. One more thing is, though we say diet is very important, you have to follow diet. In pregnancy, I know it is
vomiting, gastritis,
sensation. So in managing diabetic patients since so many years, we know following diet is not easy.
Yes.
So it takes many years for someone to change their diet to proper diabetic diet. It's a slow process. So in pregnant women, we have to be little easygoing. We should all understand here why we are controlling these sugars. So doing diet, taking medications, all are important. But why are we controlling sugars? We want a healthy pregnancy, mother to be safe and the baby to be healthy.
Yeah.
That is the final goal of managing, like even you managing a pregnancy, we managing diabetes. In a pregnancy, the end goal is
both mother and
baby should be. So to do this, we need normal sugars. Either you achieve these normal sugars with diet
or with
medications or with insulin is all same.
Yes. So sugar should be under control. Whether it is with insulin, without insulin,
it doesn't matter.
Yeah.
So we say, okay, these are the options you have. Now you're diabetic, you have diet. If not, we have medications. If not, we have insulin. So be comfortable. Try to do your diet. If you can follow. If you cannot follow, we are here.
Yes.
We can manage.
Yeah. So we have to just explain them that, we are here to work together, that nothing will happen. Insulin is very safe. A lot of women have this myth like, if you have taken insulin, it will be a lifelong problem. Do you really think so? And how do you pacify, say, for these women who are worried that if they are on insulin, it will be a lifelong thing?
Convincing pregnant women is much easier than convincing a non-pregnant person. So because pregnant women think of the baby as well. One more important thing is why pregnant women get easily convinced, because after the pregnancy, you don't require insulin. Many people believe if I start insulin, because the parents or grandparents, someone at home might be taking insulin and continuing insulin since last 10 years or 5 years. There is no stopping. So these people also get scared. The moment you say insulin, they think I'm age 30, I'm starting insulin now. Insulin may be there for the rest of my life. But in pregnant women, the moment pregnancy is complete, your lactation is complete, we'll be off the insulin.
So it's easy.
We are only giving insulin in pregnant women because many of the diabetic medications safety is not known.
So insulin doesn't cross the placenta. So that is why it is easy for a woman to take insulin, and most of these women do not need insulin after delivery. How do you decide when do you decide to start these women on insulin?
First things, monitoring.
Nutrition.
Let the values come, and then we give a diet, and then we follow. So few patients who are allowed to walk, we give a 15 minute small walking sessions after the major meals. So we look at with this. So if these are not sufficient, then we add, like say, metformin drugs. So then we monitor. We give 15 days usually, see how the values are. Till if it is not coming in line, then that is the moment we say, okay, maybe let's think of insulin. And some patients, even if they're doing well, at the start of pregnancy, they might do well. But once the 24-week crosses, usually the placenta starts forming, and then it resists the insulin action a lot. So then again, the values tend to shoot up. Like say from 24 till 32, 33 is where we see a big spike in their sugars. So if you are already on medications, if the values are going high, then that's the moment we say, okay, till now we managed. I think now it's the time. If you start insulin, it's good for you for the delivery and then for the baby to grow healthy.
Yeah. So basically, as a pregnancy increases, hormones also change, and the requirement of need for insulin might increase. So that is because of the insulin resistance increases, progesterone increases. So that is why the need of sugar monitoring is very important. So lot of people think that, my sugars are under control. I don't need to monitor because once they are under control, but you're trying to say that it is not like that. Then even though the sugars are under control, they need to check regularly.
Yes. So what is monitored is controlled.
Yeah, that's what we know. Yeah. Sugar monitoring is very important, and depending upon your sugar monitoring, your treatment goes about. So you should be very disciplined, taking your diet properly. Do not take, even though sugars can be managed, they should not take those things easily. So what are the effects of uncontrolled sugars, unmonitored sugars for mother as well as the baby?
So complications. We can divide into early pregnancy, mid-pregnancy and late pregnancy. So early pregnancy, like say someone is pregnant now and the sugars are quite high. Most commonly we see congenital anomalies. That is what we are mostly worried about.
That is why we probably want HbA1c to be
under control. Second could be miscarriage. There are two things which we are worried about in early pregnancy. Coming to mid-pregnancy, wherein like the second trimester, 3 to 6 months. So here we are worried about the baby growing faster. Since sugars go and insulin doesn't cross, so baby might get more glucose and then baby might make more insulin and then the baby might grow.
Growth of the baby
might be bigger. So we see large babies. So once there is a large baby, then there is difficulty in labor. Yeah. There could be shoulder dislocation during delivery of the baby. These are two things which
we are worried about. That is why maintenance of sugars are very, very important, so that the baby is growing well. As an obstetrician, for me, uncontrolled sugars effect on the baby and sudden IUFD is the most difficult part.
That's the late pregnancy wherein we are mostly worried about the maternal side of the polyhydramnias and then stillbirth.
Stillbirths are the late things. Whenever we see a HbA1c more than 8 or 9, these are the women which we normally ask them to have frequent scans, especially 1 or 2 additional scans than a routine care, fetal 2D echo to rule out the anomalies, all the structural anomalies in correlation with the fetal medicine department. Is there anything else which you also tell the patients that, sugar control is very important throughout the pregnancy, effect on the kidneys or any other organs, or diabetic ketoacidosis, any infections, a diabetic mother suddenly catch some infections. How do these two things has an effect on the mother?
So any complication, if their mother is already diabetic, then it becomes much worse. So that's what we educate them. Beauty of this is most of the diabetic pregnant women or gestational diabetes, the sugar values are not too high compared to the diabetic population.
Okay.
So the complications which we see in diabetic population as such don't really come in pregnant women
because they're
because they're
regularly
well controlled, monitored, and then controlled. So we are not seeing them, but we advise them. First important thing is monitoring. Monitor regularly, at least once a week you monitor, and once a month you visit your doctor.
Yeah, that is why it's more important that you should be in consultation with your endocrinologist if you have diabetes in pregnancy. And there are some times, like, when we are expecting a preterm delivery, we do administer these corticosteroids for lung maturity of the baby. How do they affect the sugars?
So yeah, this is one period where we get a lot of calls, I think, whenever they're admitted. So already a diabetic, if your sugars are high, we all know steroids can shoot up sugars. When they're admitted and then when the steroid shots are given, those 2 to 3 days, usually the sugars skyrocket sometimes. We try to manage as much as possible. Here also one more thing, diabetes affecting the pregnancy, but it's not like that one value shoots 250, 300. The next day, all the effects will not come.
Yeah, it's a
linear,
prolonged.
yes, it's a chronic and linear effect. So every day your values are consistently high. These leads to all these effects.
Changes which affected the baby.
When you give steroids, it's only for 2 days.
Yeah.
So the higher sugars might last 3 to 4 days at the max. So these will not really affect the pregnancy completely.
Your insulin requirement for those
2 to 3 days might go up. We can manage it. We are not, when we are managing also, we are not normalizing it completely. We want to keep it slightly higher only, because 2 to 3 days later when you go home, you should not get low sugar.
Low sugars also.
That is also an emergency.
Yeah.
So many a times we tell people, these 2 to 3 days, your sugars might be high. So don't be worried.
Yeah, so we'll tell them what are the normal values, low values and high values when you report to the hospital.
Whenever they're getting admitted, when they're getting a shot, we tell them, these 2 to 3 days, you're not getting your normal sugars. So don't be in a panic mode.
Yeah.
So your sugars will shoot. We will try to manage at least 80 to 70% of what is normal. So beyond we will leave, because we don't want a low sugar at the end of 2 to 3 days. So 2 to 3 days in overall 9 months of pregnancy is not much.
Yeah, so basically they have to continue the same diet, increase those 2 to 3 days or max a week. That increase in level of insulin might be needed, and then you'll get back to your previous insulin or previous
doses after your shots are done.
In labor, again, are there any change in the management? Because labor, again, is a prolonged thing, right? Normally, sometimes we might not give food during labor and all. So how do we monitor blood sugars during labor?
So I think that time it comes into the ICU kind of management, wherein we do once in 4th hourly and then see if any correctional doses are required. In case we are doing a very long-acting insulin, we try to skip the long-acting insulin a day prior. So like say tomorrow you're planning, maybe the night prior we might skip the long-acting, and then the next day we manage it with the short-acting
insulins during labor. Yeah. So now you understood what is the importance of diagnosing diabetes in pregnancy, how to take care. So it's very important to choose your hospital where all these facilities are available, like obstetrician, endocrinologist, fetal medicine department and neonatologist, where all work together to make your pregnancy much safer. Here at BirthRight by Rainbow, we provide you all facilities where we take care of you, your pregnancy, your babies and your medical part of pregnancy in a smoother way. For more such informative videos, follow, subscribe, like and share BirthVibe by Rainbow Hospitals. Thank you.